student lecture. Where is it? Here it is, number 1 normal. Okay,
Where did it go?
it's right here.
Okay.
Good. So we
let
can
me
do
get
back to the other.
let me actually download
Here,
my
we
own
can-
presentation.
Here, wait, let's, don't we have to do this? Wait.
You can just, I think on PCs you can just remove it.
Turns off. Okay.
Okay, I'm going to borrow this for a minute.
Are you
so I
going
can
to use?
transfer.
Oh, sure. We will take that out then. Where are our students here? There's something here that turns it on.
Can anybody? Yeah, I think it's on. Okay.
Could you just take that now? Sure. Thanks. Perfect.
All right, so welcome everybody to the renal and urology section of the Body and Health and Disease. All right, yes, I see a lot of enthusiasm. All right, congratulations for making it after your exam here. This is good. I'm Ali Garavi, I'm your course director, and I'm going to start with a few sort of housekeeping things with the introduction, and then we're going to launch right in. So this is going to be a fun. It's going to be a fun month ahead of us. We've already had a lot of basic understanding of physiology through your cardiovascular section, the pulmonary section, and this is where you're going to put a lot of things together because the kidney is interconnected to everything else, and it is really important for maintaining whole organismal homeostasis. And so that's how you're going to integrate a lot of the function of different organs now together, as you will see. And so we're going to work by themes. There's the first week we're going to follow normal structures, sodium and water handling. As you can see, each one of you has a bottle of water in front of you, or some form of water because it's had caffeine in it. And so we all need to, when we ingest this, we need to handle this, and your kidney is really responsible for maintaining your salt and water homeostasis. We're going to talk about intrinsic and extrinsic causes of kidney disease. Then we're going to launch into acid-base potassium and some of the divalent ion metabolism, and talk about chronic kidney disease and what happens when kidney function ceases. And then what we can do to treat patients who have kidney failure. So it should be a lot of fun. It's a multidisciplinary approach. We have a lot of different lecturers from different departments in medicine, genetics, pathology, urology, physiology, cell biology, radiology, informatics, and we all work together. We will have tandem lectures together. We expect active participation from you guys. I think that this is going to be a little bit different in some shapes. We're going to still have the preceptor-led questions in the small group sessions, but we also have student-led questions, and there will be an assignment that I will post. So the TBL groups will be responsible for teaching one another, at least for one question during these small group sessions. We're going to have team-based learning. You guys already know how to do this. We're going to have a review session, advanced topics, and then pathology labs, which you will get started on pretty quickly. So in addition, a special feature of the renal section are the clinical rotations. You will have a chance to rotate with one of our clinical preceptors in the hospital to see some of the renal patients and actually apply some of the things we learned in class to patient care. And I think this really helps provide the sort of the clinical correlation to what you learn in class, and that will put things into perspective for you. There are a limited number of spots available, so you should sign up. There's a sign-up sheet we're going to put up, so you should do this sign up as quickly as possible. It's a lot of fun. Most people come away with really good appreciation of the material after they rotate in the hospital. So I encourage you to all take advantage of this. The reference material, we use things that are online, Physiology, Harrison's, and Robbins. This is all available freely for you to look at if there are things that are not clear. But the primary material will be covered in lecture. And so we will communicate with you with email, class announcements. There will be all the material will be posted in Courseworks, of course, the case discussion. We also have a syllabus that we post. It's an old syllabus, but there are some features in there there are some sections that are very clearly written and still apply to the physiology, and some people find this helpful. So this is not mandatory to read, but maybe a useful reference material for you. At some point, we will post extra problem sets for you to start practicing the material. And then for each lecture that we give, there is going to be a lesson plan which summarizes the main points of each lecture and also tells you what are the main things you should remember. So that provides some structure for you to start to revise, you start to review the material. And so people have found this to be useful as well. So these will be posted ahead of time this year, so you can start looking through these before the lectures. So practical things like the exam, yes, there is an exam in renal. 85% of it counts for 85% of your grade. 15% of that comes from the quizzes and the TBLs, the usual format. The course is pass-fail, and so it should have we should have very little pressure on you because it is pass-fail. Yet every year there are people who fail, and inevitably people who fail are the folks who did not keep up with the material from the beginning, because we build on the initial material. So it's very tough to sort of catch up if you start halfway through the course. It's not like, if you don't know bacteria, you can still learn about parasites. You have to learn the initial material. It provides a foundation for the entire course. So keep up with the material and you'll do just fine. So this is you know how to get in touch with me. We also have 3 associate directors, Angelique Ganda, Christoph Kurlach, who will be here most of the time, I think, during the lectures. You can always come to us, and Rosemary Samponia. You can always come to us if you have some questions, and I have office hours, but then via email, most of us are available. Your small group preceptors are available, so your lecturers are also available. So that being said, let's just launch with to the introduction. Do we have questions? All right. So it's a pleasure to give this first talk with Dr. Vivek Degadi, who is the chief of renal pathologists, one of the foremost kidney pathologists in the entire planet. And so you will learn about this from people who she has described a number of original kidney disorders just in the past, few years. And so she's really an expert. And so you will reflect back on this experience in your renal section, really thinking a lot about what Dr. Degadi has taught you. So we're going to do this as a tandem lecture, talking about both structure and function of the kidney. And we'll start with disclosures. We have none. And we'll start with the teaching objectives, which is the introduction to the normal anatomy and histology, the blood vessels, the glomeruli, the tubules, and the interstitium. We will define all of these terms for you. We'll tell you what a nephron unit is, and then talk about some of the functional and physiological correlations to the structures that we're going to describe here today. So, how many kidneys do we have? 2, very good. Okay, are there people who have 1 kidney? Yes, statistically speaking, somebody in this class has 1 kidney. And so 1 in 100, you don't need to identify yourselves if you know, it's fine. Do we feel our kidneys? Do you feel your kidneys working right now as you're, no, we don't feel our kidneys. It's probably, it's not like your heart, you feel it palpitating. You don't usually feel your kidneys unless you have a kidney stone, and that's really painful, and then you know you have a kidney. The kidneys are, we have 2 of them, they're symmetrical, they're not quite identical. And they're retroperitoneal structures that are sort of underneath our rib cages. As you could see, they get 20% of the blood flow, and the renal artery on the right side takes off a little bit lower because we have the liver here. On top of the kidneys, what do we have here? The adrenal glands, they sit on top of the kidney, and they have important functions for regulation of renal homeostasis as well, as we will talk about. This is what a kidney looks like. It's about 10 to 12 centimeters in an adult individual. You have these lobulations that you can see. This is a pediatric kidney. It's very small, and you can see the lobulation more prominently. This is a formalin fixed kidney. You will later see a picture of what a kidney actually looks like in vivo without fixation. What do kidneys do, and what happens if the kidneys fail? So the kidneys have a lot of different functions. Most importantly is waste disposal. We have metabolic needs, and we ingest food and water and salt, and those all have to be, byproducts of metabolism has to be disposed of. If you don't have kidney function, this waste accumulates in the body and contributes to a syndrome called uremia, which affects multiple organs. We will learn about this. We regulate salt and water balance, and so if there is no kidney, then all the water and salt that we ingest every day accumulate, and you start having it builds up in your body, and you develop a lot of issues with breathing, for example. High potassium, hyperkalemia, high phosphate in the body, which is also toxic. The kidneys also regulate acid-base balance. Almost everything that we ingest on a Western diet has an acid load, and so again, the kidneys has to excrete the extra acid and regenerate base, so we maintain a normal pH in our body. The kidney also has endocrine function. It synthesizes this hormone called erythropoietin, which you've learned about this, right? It's important for red blood cell development, and so if you don't have erythropoietin, then you don't make red cells and you develop anemia. It's important for vitamin D metabolism, and so again, if you don't have kidneys, then you don't have enough vitamin D. Your calcium balance is perturbed, and you develop bone problems. The kidneys also metabolize insulin, and so it's important to know about this because as kidney function decreases, then there's less insulin that's metabolized and degraded, and patients can develop hypoglycemia. So particularly diabetics who are already taking insulin, if they develop kidney disease, then requirement for insulin decreases over time because their kidneys are failing and they're not metabolizing the insulin as much. We'll go over all of these things, but just to give you an idea that the kidney has very complex functions, and so when you start having kidney problems, there's a lot of issues that develop throughout the body and affects multiple organs. So the functional unit of the kidney. So is the kidney one gigantic filter? In fact, that's not it. In kidney we have a functional unit, small filters attached to tubules, which is called the nephron. And so you will hear today about the structure of the glomerulus, which is the kidney filter, which is then connected to this really complex set of tubules. This is called a nephron. We have about 1 million nephron per each kidney, as depicted here in this picture of a developing kidney. Each unit here is a renal corpuscle, which will give rise to a nephron. And so we were going to spend the next hour or so discussing the composition of the nephron and the structure of the nephron, and you will see. So, without further ado, Dr. Degati.
welcome to a new class, and it's my pleasure to take you through the pathology of the kidney, but what we're going to focus on today is the normal structure to lay a groundwork for your understanding of the diseases that follow. And I always like to start this lecture, probably because I'm half Sicilian, remembering a fellow Sicilian, Marcello Malpighi, who at the University of Messina was actually the first to identify the glomerular filter. And he did this. It's amazing to think 350 years ago, but the best anatomists of the world are actually located in Sicily. And what he did was to inject India ink into the main renal artery. He then decapsulated the surface of the kidney, and he took a very crude microscope and looked at the structures that he saw lighting up with this India ink because they were rich in capillaries. And what he saw was the capillary plexus of the glomerulus, which we now know is the filtering organ of the nephron. And he recognized, amazingly, the relationship to the tubule. He recognized a capsule that houses this capillary bed, which we know of as Bowman's capsule because it was later described by a man named William Bowman. He recognized two small vessels that we now know are the afferent and efferent arteriole that enter this capillary plexus. And amazingly, he even saw a little nerve. I think he imagined this because even with our high-power electron microscopes, we can't see any nervous innervation, but we know there is sympathetic nervous innervation to this region, to the region of the juxtaglomerular apparatus. But in 1666, Malpighi saw it. And he made only one mistake. He thought this structure was actually an endocrine organ that secreted urine. He didn't realize that it was a filtering organ that filtered the plasma proteins and solutes to make urine. So let's look at the gross anatomy of our kidney. You saw what it looks like after formalin fixation. It gets very pale. But if you take a kidney right out fresh at autopsy or at surgery, this is actually what it looks like. It has a kind of brick brown, red-brown appearance, and it measures in the normal somewhere between 10 and 12 centimeter in length. You can see that it has at the medial surface a kind of convexity here, through which pass some very important structures. You have your renal pelvis and ureter take off here. You have the main renal artery and vein entering here, and a lymphatic plexus. And you can see that there is a capsule, which here the pathologist has retracted. The capsule covers the entire kidney. It's translucent. It's less than a millimeter in size, and in a normal state, it's easily retracted off the kidney. It's not adherent. But when you have disease states where there's been inflammation or contraction of the kidney, it may become densely adherent. Notice that in the adult, the surface of the kidney is relatively smooth. You may have some simple tubular cysts on the surface, which is not uncommon, but the fetal lobulations that Ali showed you earlier begin to disappear as the kidney gets older, and in the adult, they're virtually inapparent. If we bisect the kidney, we can see the two main anatomic compartments of the kidney, which are known as the cortex and the medulla. The cortex is the outer portion, which is kind of a tan brown in appearance, as you see here, and measures about 1.2 to 1.5 centimeter in thickness normally. The inner portion is known as the medulla, and it is composed of anywhere from 8 to 18 striated conical segments known as the renal pyramids. And the reason they're called pyramids is that they really look like an upside-down pyramid with the base at the corticomedullary junction and the apex extending towards the calyx, where urine exits here through the most distal ends of the collecting tubules into the calyx and then enters the pelvis here to be then later transferred to the ureter. And you can see that along the lobes of the kidney, at the edges of the kidney, we have some complex papillae where several papillae come together into one calyx, but in the central portion of the kidney, over the mid portion, we have individual pyramids as shown here. You'll notice something else, which is that the inner portion of the papilla is relatively pale, and you begin to see a striped appearance to the medulla. And we're going to go over what this striping corresponds to shortly. I also want to call your attention to the cortex, where you see some faint striations extending to the surface here. These represent straight portions of the nephron that are actually situated in bundles, and as they extend down into the medulla can be seen and are known as medullary rays. So these are collections of straight portions of the nephron coming from the more superficial glomeruli. Now, as we approach the different diseases of the kidney, you're going to hear us talking about the different compartments of the kidney, and that's how our course is structured. And the reason why we do this is because there is differential susceptibility to diseases of the various compartments. So that the glomerular diseases, for example, as you'll hear, are mostly immunologically mediated, whereas tubular diseases tend to be more ischemic or toxic in nature. When we talk about interstitial diseases, we're going to be talking mostly about inflammatory conditions, whether it's infection or an allergic reaction to a drug, what we call interstitial nephritis. And when we talk about blood vessels, we're going to concentrate mostly on the effects of hypertension and how this can injure the blood vessels of the kidney. So these are the four main anatomic compartments we're going to talk about. And all of these are located in individual nephrons. A nephron will have a portion of each of these compartments within it. So here, let's look at an individual nephron. Ali showed you a picture earlier. You can see how there is an afferent arteriole that feeds blood to this capillary plexus, which is the glomerulus, an efferent arteriole, which then passes out and supplies blood to the tubular system. If you look at the black arrows, you can see the direction of the filtrate. As it leaves the glomerular capillary, it enters the proximal tubule, which has convolutions, and then a straight portion known as the pars recta, enters a thin descending limb, a thin ascending limb, back up to the thick ascending limb of the distal tubule, which again has convolutions located in the cortex, and then heads down again as the collecting tubule. So this is a very serpentine structure. It looks like almost like an S, which is sideways. You go down into the medulla, you go back up, and then you go down again as a collecting tubule. And you'll see how this unique anatomy allows us to really concentrate our urine as we go down into the inner portion of the medulla, depending on the needs of the organism. How is this situated within the gross anatomy that I showed you? Well, here's an individual nephron unit, and you can see from this picture why the gross pathology looks the way it does. The glomeruli and the convoluted tubules, both proximal and distal, are all located within the cortex, whereas the straight portions here, the thin limbs and the collecting tubule, are located in the medulla. So that's why this area looks more striated, and this area has a more complex look because of the convolutions. So you will never find glomeruli in the medulla. You will never find these convoluted tubules within the medulla. They're all housed in the cortex. As we look at the nephron units, keep in mind that there are several different populations of nephrons. We have some that are located more superficially. They're known as outer cortical nephrons. We have others that are located close to the medulla, which are known as the inner cortical nephrons or juxtamedullary nephrons. And you can see from this picture the glomerulus. You see how the filtrate enters into the proximal convolutions, shown in blue, heads down into the thin limb, descending and ascending. The thick ascending limb, again, are distal convolutions, and then enters the collecting system to be discharged at the base of the medulla. I told you there was a striping within the medulla, and you can see why this is so. You can see that the outer stripe of the outer medulla is enriched, particularly in the pars recta, or straight portion of the proximal tubule. And in this inner stripe of the outer medulla, we have an enrichment of the thick ascending limbs. Whereas in the most inner portion of the medulla, which is known as the papilla, we're dealing mostly with the thin limbs and with the inner cortical collecting ducts and the vasa recta, the vascular supply that follows them. Here's what it looks like in a histologic section. This is taken from a mouse kidney. You can see the surface of the kidney here. You see that the glomeruli are relatively small structures, and the vast bulk of the kidney is actually comprised of tubules. And at the corticomedullary junction, we have here the transition to the outer stripe of the outer medulla where the straight portions of the proximal tubule are located, and you can see them here with their rich brush border shown in the PAS stain. But this shows us how about 90% of the volume of the kidney is actually tubular. The glomeruli comprise a small portion. As we go into the cortex, remember I told you about the medullary rays that we could actually see in the gross kidney. These are groupings of the straight segments of tubules as they descend towards the medulla from the more superficial nephrons, and you can see them here dividing up the cortex as a labyrinth between these medullary rays. Now, as we look in our usual sections that we do for histology, and you're going to see a lot of these as we go through the different diseases that we deal with, you can see the glomeruli here, which seem to be floating free within the urinary space, or known as Bowman's space, except if you have a fortuitous cut that shows us the hilus of the glomerulus, where the afferent arteriole comes in, and you can see here where it's connected now to the vascular supply. And see again how many of these tubules are proximal, the vast majority, and some distal convoluted ones are seen here, and here are a few vessels. But the interstitium is relatively inapparent in the normal state. In disease states where we have inflammation or edema or fibrosis, we can see much of the interstitium more clearly, but in a normal state, it's a really very small space. So as we talk about the glomeruli, because these are really a specialized vascular bed, it's important to go over the vascular supply of the kidney in general. The kidneys, although they're only about 0.5% of the total body weight, receive anywhere from 20 to 25% of the cardiac output. So 0.5% of the body weight, but 20 to 25% of the cardiac output. That's an amazing statistic. And so these are richly vascularized viscera. What we have here is the main renal artery, which does not pierce the kidney directly. It actually divides at the hilus into an anterior and posterior division. These then give rise to segmental branches, which are shown here, supply blood to the different portions of the anterior and posterior kidney. And then once they get close to the parenchyma, they divide into interlobar arteries. Each renal pyramid with its overlying cortex is known as a lobe of the kidney. And so these arteries now extend between the individual lobes of the kidney. And when they get to the corticomedullary junction, they arch, forming arcuate arteries, which you see here, which then extend as straight arteries to the periphery. And these are the interlobular arteries, and it's off of these interlobular arteries, which are little small twigs here, that the afferent arterioles come off and actually supply blood to the glomeruli, and we'll see this better. So here is actually a dissection of the interlobular arteries, and you can see how these are straight arteries going to the periphery of the kidney. And the glomeruli look almost looks like a forsythia bush here, with these little flowers, which are the glomeruli coming off the interlobular arteries. But only when we look on higher power do we see the relationship that these interlobular arteries give off in series afferent arterioles, each one of which supplies blood to a single glomerulus. So this is an important concept because each of these arteries is an end artery, and there are no interanastomoses in this system. So if you have disease here, more proximally in the beginning of the interlobular artery, or let's say the arcuate arteries that narrows them or occludes them, you are going to have ischemic effects on the glomeruli, which depend on this blood supply. So here are some vital statistics on the glomeruli in man. If we consider we have 2 kidneys, there are roughly 1 million per kidney. Now, this is not an exact number. It depends on your birth weight and how well nourished you were in utero. There's a big variation. But in general, we have about 1 million nephrons per kidney. So 2 million in total. And as I said, the volume of the kidney is only about 9% of the entire cortex, and even less by weight. But if you were to take all the glomerular capillaries and unravel them and string them up one after the other, you would produce a huge megacapillary from these 2 kidneys that is 2 kilometers long. That's an amazing statistic, but only 7 microns in diameter, which would give us a surface area of about 1.6 square meter. So this is an incredible scenario where you have a structure that is uniquely designed, it's minute, and uniquely designed to maximize the surface area for filtration. We're going to talk about the different cellular components of the glomerulus, and you're going to hear about these more when we talk about individual diseases and how they become perturbed in different disease states. But we're going to talk about 4 cell types: the glomerular endothelial cell, mesangial cell, the visceral epithelial cell, which also goes by the name of podocyte, which is a very unique cell, and the parietal epithelial cell that lines Bowman's capsule. So here's what they look like diagrammatically. This is the glomerular capillary plexus shown here. You can see the afferent arteriole coming in, the efferent coming out, the plexus of capillaries. You can see that the mesangium shown here with its red mesangial cells and blue matrix is a kind of support system for the capillaries. It looks like the trunk and branches of a tree. The capillaries come off it. They are lined by the yellow cells here, which are the endothelial cells. We have a single endothelial nucleus per capillary. And you can see glomerular basement membrane, and then on the outer portion of the glomerular basement membrane, the visceral epithelial cell, or podocyte, which is this large cell here, which has these small little projections here, which are known as foot processes that extend to the surface of the glomerular basement membrane. This is a bit like the pleura or the pericardium, where you have a visceral and parietal layer, the visceral layer being the podocyte, the parietal layer being the parietal epithelial cell, and the space that we're talking about here, rather than being the pericardial space or the pleural space, is actually the urinary space, which is actually known also as the Bowman space. So Bowman space or urinary space, and the capsule that is lined by these parietal epitheliums is known as Bowman's capsule. Now, there's a very specialized area here, right at the hilus, which is known as the juxtaglomerular apparatus, the JGA, and you're going to hear more about this area. This is the area where we produce renin, which is a very important hormone. It's actually produced by these granulated cells in the smooth muscle of the afferent arteriolar wall, and you can see them here. And renin is important in the production of angiotensin II. You're going to hear about this from Ali. And it can actually be produced in response to different stimuli, pressures at the level of the afferent arteriole, the amount of sodium chloride, in particular chloride, that's presented at the level of the distal tubule, which touches the glomerulus right here in a specialized area known as the macula densa. And also there's sympathetic innervation to this area as well. So this is an endocrine organ, really, the juxtaglomerular apparatus. And if you consider we have 2 million nephrons, and you add all that up, you're going to have an endocrine organ about the size of the adrenal medulla. I mean, this is a sizable organ and a very important one. So this is what the capillaries look like in 2 dimensions. You can see the tubular pole here, where the filtrate now enters the tubular system and is modified by reabsorption and secretion at the level of the various segments of the tubule, which Ali will discuss. But that this is diametrically opposite the hilus, or vascular pole, of the glomerulus. So in 2 dimensions, this is what the capillaries look like. But what they're doing in 3 dimensions is much harder to understand. And years ago, people did serial sections ultrastructurally of the glomerulus and then did a reconstruction of the glomerular capillaries and found that there were actually divisions, a series of dichotomous branchings of the afferent arteriole into afferent and efferent limbs, anywhere from 6 to 8 per glomerulus, and that these then had interanastomoses that course through the mesangial regions, as you can see here. Then these come together as the efferent arteriole. Now, the important point I want to make to you here is that this is a unique capillary bed, the only one in the body that's located between 2 arterioles. Every other capillary bed you can think of in the body is located between an arteriole and a venule. And the reason for this, it's almost like a balloon between 2 stopcocks, where you can control the pressures by the level of constriction of both the afferent and efferent arteriole. If you constrict the afferent too much, you're going to lower the pressures in the capillary beyond a certain level. If you constrict at the level of the efferent, you can raise pressures back up inside the balloon. And so we can modulate this with the use of particular drugs, and you're going to hear about the angiotensin-converting enzyme inhibitors and how they modulate the efferent arteriolar tone. So the driving force for filtration, as for the movement of fluid across all capillary beds in the body, is generated by the hydrostatic pressure that comes from the pumping action of the heart. And it can be expressed, according to Starling's mechanisms, by the following equation, that a single nephron glomerular filtration rate, or GFR, is an ultrafiltration coefficient, Kf, times the difference in hydrostatic pressure between the glomerular capillary and the tubular pressure, and minus the difference in oncotic pressure between the glomerular capillaries and the tubules. This ultrafiltration coefficient is actually the product of the permeability of the glomerular capillary wall itself, K, the hydraulic permeability, times the surface area available for filtration, again, times the delta P minus delta pi. Now, if we consider that the oncotic pressure in the tubule is virtually nil because albumin is largely excluded, then we can roughly say that if we want to figure out our effective filtration pressure, it's the glomerular capillary hydrostatic pressure minus the oncotic pressure of the glomerular capillary minus Bowman's space hydrostatic pressure, which gives us about 10 to 15 millimeters of mercury. This value of the hydrostatic pressure in the glomerular capillaries, again, is not related in any simple way to the mean arterial pressure, but to the balance of pressures between the afferent and efferent arteriole. It's the highest pressure, hydrostatic pressure, of any capillary bed in the body, again, favoring the filtration process. So what happens to the blood as it leaves through the efferent arteriole? Well, that depends on whether we're an outer glomerulus or an inner cortical glomerulus. Those that are in the outer portion, the more superficial glomeruli, give rise to a vascular plexus that feeds the cortical tubules, known as the rete mirabile, the miraculous net in Latin, and it surrounds these tubules here. Those that emerge from the inner cortical nephrons give rise to the straight vessels, the vasa recta, that descend into the medulla together with their tubular system and essentially prevent washout of the osmotic gradient that's produced by the inner nephrons, and you're going to hear more about this. So we have two systems in parallel, one a high-pressure system favoring filtration, one a postglomerular circulation, a low-pressure system favoring reabsorption of fluids and solutes at the level of the tubule. You can see here the anatomic interdependence of all these different compartments. All the glomeruli depend on a vascular supply. They are connected to a tubule. If you have a disease, for example, that affects the blood vessels and then prevents blood from entering the glomerulus can undergo sclerosis, the tubule can undergo atrophy, the interstitium can become fibrotic. So all of these different compartments are related to each other. And that's why in the end stage, when diseases become very chronic, we begin to see disease in all the various compartments of the kidney. So these efferent arterioles that give rise to the rete mirabile or peritubular interstitial capillary plexus are not very visible when we look at a routine section, but I've taken this section from someone who died of passive congestion at autopsy. He died of heart failure. And you can see now the capillaries, because there's passive congestion, are filled with red cells. And you can see how each proximal tubule is ringed by a system of capillaries. And it's this close apposition of the capillary system to the tubule which allows these capillaries to receive the reabsorbed components through the tubules. Remember, about 90% of what passes through into the proximal tubule is going to be reabsorbed and delivered to the capillary plexus. So this anatomic proximity is very important in the reabsorption process. So let's talk about the different cellular elements and matrix elements of the glomerulus. Looking here at very high power at a silver stain. The silver stain is a stain we like to use in kidney pathology because it highlights the basement membrane of the glomerulus very well and the matrix components. And you can see here the mesangial area, the mesangial cell with its surrounding matrix. Here's another one that supports the glomerular capillaries. You can see the glomerular basement membrane shown in black. We can see the endothelial cells that line the capillaries, the mesangial cells within the stalk. We can see here the podocytes, or visceral cells, that are on the outer aspect of the capillaries. And here is Bowman's capsule, and you can see these flatter cells, which are the parietal epithelial cells. If we look with electron microscopy, and you're going to get used to looking at electron microscopy because we use it as part of our diagnostic workup in kidney disease, here we're looking at several glomerular capillaries. This is the mesangial area. And here's the mesangial cell with its surrounding matrix between two adjacent glomerular capillaries. Here's the glomerular basement membrane. Here's the endothelial cell. And the point I want to make is that the endothelial cell sits with its nucleus and cell body directly on the mesangium. And the reason is it doesn't want to obstruct the passage of filtrate through the peripheral capillaries, which is how we filter. So if we had the cell body out here, it would be in the way of the filtration process. So it's located here next to the mesangium. And here along the periphery, we have a fenestrated endothelium that lines the glomerular basement membrane. And here's the podocyte sitting out in the urinary space that's sending its foot processes to the surface of the capillaries. If we look at very high power at the peripheral glomerular capillary wall, we can see the endothelial cell with its fenestry. We can see the glomerular basement membrane. We can see the podocyte foot processes, which form these pedicels that insert onto the glomerular basement membrane. And they are bridged by a tiny diaphragm known as the filtration slit diaphragm, or slit membrane, and we'll talk about this in a little more detail later. So this is kind of a sandwich of basement membrane between two cellular components, the podocyte foot processes and the endothelium. The endothelium is highly fenestrated, and so for a filtering organ, it shouldn't surprise you to learn that this is the most highly fenestrated endothelium in the entire body. About 30% of the surface of the endothelium is fenestrated. These fenestri measure between 70 and 100 nanometer. They're pretty wide. And where these cells make contact with each other, we may see ridges. So they're non-fenestrated ridges where there is cell-cell contact. Moving on to the mesangium really arises from the smooth muscle, as I showed you before, of the afferent and efferent arterioles. And I like to think of it as a tree-like structure. It has a trunk that originates from these smooth muscle cells of the afferent and efferent arteriole, and it has branches which ramify and support the glomerular capillary plexus. The mesangium is composed of mesangial cells and the matrix that they produce. And in a normal state, we shouldn't have more than 3 of these mesangial cell nuclei in the periphery of the tuft, as you can see here. In disease states, when the mesangial cells proliferate, they become more numerous, as we'll hear about. So what is the relationship of these glomerular capillaries to the urinary space and the matrix elements? Here's Bowman's capsule. Here's the tubular pole. Here we reflect onto the glomerulus at the juxtaglomerular apparatus. And you can see that all these basement membrane components are actually continuous with each other. You have tubular basement membrane reflecting onto Bowman's capsule reflecting onto the glomerular capillary plexus, mesangial cells and matrix shown here. These convolutions here are the capillaries. And you can see that the endothelial fenestri are shown here, the cell body and nucleus sitting on the mesangium. And the important point here is that each glomerular capillary is not encircled by basement membrane, but it's open at the mesangial angles. That means that this high hydrostatic pressure we talked about, 40 to 50 millimeters of mercury at the level of glomerular capillaries, is going to be felt by the mesangium. So the mesangium has to generate its own inwardly directed pressure to counteract these hydrostatic or outwardly directed pressures. And how does it do this? Well, by the unique anatomy of the mesangial cell, which I think of as a kind of specialized pericyte. It has smooth muscle characteristics, a bit like the smooth muscle cells that are lining the afferent and efferent arteriole. And here you see in the mouse the mesangial cell with its processes. They're rich in actin myosin filaments, and they actually tether the glomerular basement membrane, preventing it from blowing out in response to these high hydrostatic pressures. It holds it in firmly, and this anatomy is important to maintain the normal glomerular structure. This cell is, not surprisingly, a contractile cell, and it can respond to a whole host of vasoactive substances. I've listed some of them here, and some of these may be substances that are circulating. Some may be produced locally at the level of the juxtaglomerular apparatus, like angiotensin II, and may be important in that tubuloglomerular feedback, and you're going to hear more about this. And they can relax in response to certain other agents, such as atrial natriuretic peptide, dopamine, and certain prostaglandins. And so these vasoactive responses can modulate the GFR. You can think that the capillary pressure is determined not only by the balance of pressures between that afferent and efferent arteriole, but also the intrinsic pressure at the level of the mesangial cell, which can fine-tune filtration by its level of constriction or relaxation. And this is illustrated beautifully here in studies that were done some years ago, where the glomerulus was perfused with a silicone rubber cast to show us the capillary plexus. Here's the normal with its afferent and efferent arteriole. And after exposure to one of these vasoactive agents, in this case norepinephrine, you can see that we have contraction not only of the afferent and efferent arteriole, but also of the mesangial cells themselves. And this can cause a rarefaction of the glomerular capillary plexus, actually preventing certain capillaries from participating in the filtration process. It just closes them off by that constriction of these interanastomoses between the lobules, the afferent and efferent capillaries that I showed you earlier that form the capillary plexus. So this can modulate GFR locally. Let's move on now to the glomerular capillary wall, which is shown here as being, again, that sandwich of cellular elements, the foot processes, with the glomerular basement membrane, and then on the inner surface, the endothelium, which here does not show any fenestrations. It must be one of these non-fenestrated ridges. And the glomerular basement membrane basically has three layers, which we see ultrastructurally, and they're much more apparent in the rodent than they are in man. That's why, not surprisingly, this picture comes from a rat. In man, they're less apparent. But there is one outer layer that's somewhat rarefied that we call the lamina rara externa, where the collagen molecules are perpendicularly oriented and tend to be relatively few. There is a lamina rara interna with similar appearance on the inner aspect. And in the center, we have a lamina densa, where the collagen molecules are more densely aggregated and more longitudinally oriented. So we have a lamina rara externa, a lamina densa, and a lamina rara interna. And then here between the pedicels or foot processes of the podocyte, we can see this peculiar structure, the filtration slit diaphragm, that we'll talk about a little bit more in a moment. As we talk about the glomerular basement membrane, it's composed predominantly of collagen. But which collagen? We have, over 14 members of the collagen family, and when I mention collagen to people, what they usually think of is the banded collagen. Collagen 1 or 3 that we have in the integument of the skin, that we have in the interstitium of the kidney, for example. This is a very tough collagen. It's very strong, but it's relatively impermeant. The collagen that we're dealing with in the glomerular basement membrane is type 4 collagen. It's the collagen that comprises the collagen backbone of vascular basement membranes throughout the body. And the reason that we have this type of collagen, which is often called the spider collagen, is that it has this kind of irregular, complex kind of meshwork when the collagen molecules line up with each other end to end and laterally. And it has large interstices, which are ideal for a filtering membrane and can maintain the glomerular basement membrane as kind of a hydrated gel. This forms a kind of chicken wire mesh throughout the glomerular basement membrane and allows for the looser attachment of other important molecules. Here we see laminin and heparan sulfate proteoglycan, which tend to be clustered in the outer and inner portions, the lamina rara externa and interna of the glomerular basement membrane. We can stain for the heparan sulfate proteoglycans with a cationic ferritin. Heparan sulfate is a negatively charged molecule, and it imparts a net negative charge to the glomerular capillary wall. And you can see the clustering of these heparan sulfate proteoglycans mostly in the lamina rara externa and interna. The net negative charge of the glomerular capillary wall also comes in some part from the cells that line the glomerular capillary wall, the foot processes and the endothelium, which have a sialoprotein coat, a glycocalyx, which is known as podocalyxin, which is rich in sialic acids. Each molecule has about 20 sialic acids and several sulfates. So it's highly negatively charged and very important in maintaining the net negative charge of the glomerular capillary wall. So we have negative charge sites within the basement membrane, heparan sulfate proteoglycans. We have them also on the surface of both the podocyte and the endothelium. So based on these structural characteristics, the glomerular capillary wall discriminates molecules based on both their size and their charge. And this was shown very elegantly in work done now back in the 1970s, but it's still a classic study that actually looked at dextrans, a test solute which has a homogeneous chemical composition but whose molecular weight can be varied, and measured the clearance of this dextran compared to a reference solute, in this case inulin, which is only 14 angstroms. It's very tiny, and it's freely filtered and not handled in any way by tubular reabsorption or secretion. So the ratio of the clearance of the test solute dextran to inulin was 1 when the test solute was freely filtered, going down to 0 when it was completely impermeant. And what you can see from these sieving characteristics is that if we look at dextrans over a molecular radius of about 20, we begin to see increased restriction of the dextran as it gets larger and larger, approaching 0 at about 42 angstroms. If we look at the negatively charged dextran sulfate, for every given effective molecular radius, we have increased restriction of the negatively charged dextran sulfate compared to the neutral dextran, approaching 0 at about 36 to 38 angstroms. Well, what about albumin? Albumin is negatively charged, and its size is 36 angstroms. If it were behaving like the neutral dextran, its clearance would be 0.15, somewhere up here. But actually, it's less than 0.01 because it is negatively charged and obviously being restricted by these negative charge sites in the glomerular capillary wall that we discussed. So we're going to move on now to the last cell. We've talked about endothelium, mesangium, the glomerular basement membrane. We're going to talk now about the podocyte, or visceral epithelial cell, which is a really unique cell and probably the most studied cell in glomerular biology over the last 15 years. Here it is by our normal transmission electron microscopy. It's a large cell that has a big nucleus and cell body. And if you have a fortuitous cut, again, you can see how the individual foot processes come off the cell body here. But it looks like it's almost floating free within the urinary space. But really the beauty and the complexity of these cells is best revealed using scanning electron microscopy. And you can see how these cells almost look like an octopus, really a unique cell in all the body. It resembles more a neuron than a polarized epithelial cell, but it is a polarized epithelial cell. And it has a big cell body and nucleus from which primary processes arise, and then these give rise to secondary and tertiary processes, which are the foot processes that interdigitate along the outer aspect of the glomerular capillary wall. So it really envelops the glomerular capillary wall with a kind of octopus-like or tentacle-like embrace, as you can see here. If we look with transmission electron microscopy, you can see something interesting, which is that no two adjacent foot processes arise from the same cell. They actually interdigitate. And you can see that even better if you look with, here with freeze etching, where we've taken 3 different podocytes and we've colored them with a different color, and you can see how these foot processes are really interdigitating over the surface of the glomerular capillary wall. So this is an important anatomic arrangement that prevents, again, these capillaries from blowing out. So these are little like stabilizing patches on the surface of the capillary. And when I was in Paris recently and I was looking at Notre Dame, I looked at the apse and I said to myself, wow, that looks like a glomerular capillary. And look at these flying buttresses. They look a bit like foot processes. And sure enough, I have seen by electron microscopy how these foot processes, like flying buttresses, actually stabilize the outer aspect of the capillary wall. It was certainly something that was known very well by the medieval and Renaissance architects of old. Well, as we look at the individual foot processes, we talked about a particular area between the foot processes, which is known as the filtration slit. And it is bridged by a diaphragm, known as the filtration slit diaphragm. Now you may say, this is a tiny structure, and it looks like it has a little central dot here. What is this? What is its importance? And I may tell you that this is actually an extremely important structure in maintaining the permeability barrier to albumin and proteins. And we're going to talk a little bit about its structure right now. How can such a tiny structure be so important? And what is it composed of? Well, if we were to take a helicopter and go up into the urinary space and look down on these filtration slit diaphragms from above, we would see these interdigitating foot processes. Here's one foot process with its cell membrane. Here's another foot process interdigitating. And between the foot processes, we have the filtration slit diaphragm. And you can see that that central dot is actually a long filament that extends the length of the filtration slit diaphragm in 3 dimensions, and it gives rise to lateral crossbars which insert onto the membrane of the cell membrane of the podocyte foot processes. And people who studied this back in the 1970s actually measured what the pore size would be of these lateral pores and found that it was about the size of albumin, and actually put forth the hypothesis that this may be the most restrictive portion of the glomerular filtration barrier on the basis of size, restricting albumin, which again is 36 angstroms. So this is known as the anatomic zipper. It looks like a zipper. And for many years, whether this truly exists was a matter of debate until people learned the molecular composition of the filtration slit diaphragm. We now know that the diaphragm is composed of a number of molecules, but the most important one is a molecule known as nephrin. Nephrin is produced by the podocyte. It's a kind of specialized cell-cell junction, a member of the immunoglobulin family of adhesion proteins. And here you can see one foot process membrane. Here's the other. Here's the filtration slit bridged by extensions of these long extracellular proteins that form a kind of modified adherens junction. It's a really specialized cell-cell junction. And you can see how the overlapping of these nephrin molecules at the center of the pore could give rise to that central filament that was described years before using transmission electron microscopy, and how we could have these side pores which would have a size that would be able to restrict albumin and larger molecular weight proteins. So on the basis of all these structures, we can think of the filtration barrier as being composed of successive layers of barrier formation. You have the endothelial cells, which prevent foreign blood elements from reaching the glomerular capillary wall. They're negatively charged, so they do repel to some degree negatively charged plasma proteins. We have the mesh, chicken mesh of the collagen 4 within the glomerular basement membrane itself, and we have these filtration slit diaphragms between the individual podocyte foot processes, the most restrictive layer and the basis of size. So through this now, our filtrate takes not a direct course, but a streamlined course and exits through these filtration slit diaphragms into the urinary space. From here, the filtrate will enter the tubular system, and you will hear about this from Ali. And we pass into the first portion of the proximal tubule, and here we have an abrupt transition from parietal epithelium to the cells that line the proximal tubule. So on my trip to Paris, I was back in Notre Dame, and I was looking at the famous rosace, and I was saying to my husband, wow, the glomerulus is a beautiful structure. And he thinks I'm crazy on all these trips. But it actually is not an inert structure that's simply under the influence of passive pressure gradients. It is an active, dynamic, multifaceted structure that's able to respond to and in some way control its own microenvironment. Well, you may say art imitates life, or life imitates art, or Dr. Degati, if you've been in this business long enough, you begin to go a bit batty and you see glomeruli everywhere you travel. And that's definitely the case, and I'm told there are a lot more waiting for me on my next trip to Istanbul. So we'll go on now to the tubule, and Ali will take over.
Isn't that an exquisite structure? So it's a lot of thought has gone into designing the kidney and coming up with evolving such an organ. And so we're going to spend the next maybe 10, 12 minutes talking about some of the physiological correlates of the kidney and also these structures that we talked about, and then we'll take a break. Okay. So we're going to go back to the nephron. You heard a lot about the structure of the glomerulus. This is the filter that we have in our kidney, and so it receives 20% of the blood flow, and it filters about 50% of the plasma that comes through it. So when you think about it, that comes out to about 200 liters a day that we're filtrating. And if you think about the tubules of the nephron, they're interconnected eventually to the renal pelvis, which then drains via the ureter into the bladder, and then through the urethra to the outside world. So in fact, anything that's in the lumen of the nephron is technically outside our body. So when we're drinking and we're filtrating, we are putting 200 liters a day outside our body. And the job of the kidney is actually to reclaim all of this filtrate and leave out what is not needed. And so that is the function of each segment of the nephron, which has specialized functions. And so that's what we're going to cover in the next maybe 10 minutes. And you will hear in exquisite detail about the function and molecular mechanisms that are responsible for these functions in the next few days. So how does that work? So you start filtering a substance, okay, through the glomerulus. It goes into the tubule. How can you handle this? A substance can simply be excreted. It's neither reabsorbed nor secreted by the tubules. And a good example of this is a substance called creatinine. You will hear about this as a byproduct of muscle metabolism. We measure creatinine in the blood, and the level of creatinine is a proxy for your kidney function. Okay? Substances can be filtered and then reabsorbed. There's a lot of segments of the tubule that are responsible for reabsorbing substances that are filtered, especially sodium chloride. And so that's the other mechanism through which this can happen. Glucose is filtered and completely reabsorbed in the proximal tubule, for example. And then we spent a lot of time reclaiming different amounts of salt in different segments of the nephron. Finally, substances can be secreted, and you will see how that will work as well. For example, this substance, para-aminohippurate, is completely secreted by the nephron. It's not something that we make. This is an artificial substance. But we secrete anion. We also excrete or transport hydrogen, for example, into the lumen to be able to excrete these substances. So we're going to go through all of these things in the course of the next 4 weeks or so. There are a lot of molecular mechanisms that are responsible for this. Okay, this slide is not there for you to memorize in the next 2 minutes. It's for you to tell you that we understand quite a bit about the complement of transporters, exchangers, channels that are responsible for shuttling various substances across from the lumen into the cells and then through the basolateral surface into the blood. Okay, and again, for each one of these molecular pathways have been fairly well elucidated, but there's still a lot we need to learn. But I think we understand the physiology fairly well, and you will learn about each one of these transporters and molecular pathways responsible for reabsorption, secretion, and excretion of different substances. So let's start with the proximal tubule. This is the first stop in the nephron. It's a segment which has, it's a high-capacity reabsorptive segment, essentially. It's responsible for the bulk transfer of water and solute. It's completely isotonic. In other words, it doesn't concentrate anything. It doesn't dilute anything. It's reabsorbed by 60% of the filtered sodium and water. This can be augmented to up to 90% under the right physiological stimulus, and it reabsorbs about 90% of the filtered bicarbonate that's in the filtrate. It reabsorbs nutrients such as glucose and amino acids that get through pass through the filter, and it secretes a number of organic anions such as formic acid, for example, but also it's responsible for secreting, for example, antibiotics and exogenous substances that we ingest. So you can think of the proximal tubule essentially as a high-capacity reabsorptive segment. And we have a number of molecular mechanisms, again, that are responsible. This is really powered by the sodium-hydrogen exchanger at the apical surface. You have your sodium-potassium ATPase that's coupled at the basolateral surface. There are a number of different pathways that are coupled to the sodium-hydrogen exchanger to reabsorb salt and actually also reabsorb bicarbonate. We will go through this in more detail in subsequent lectures. In terms of the anatomy, the proximal tubule, because it has to reabsorb so much, has evolved this really intricate brush border, which is this infolding of the membrane, which again increases your surface area and your capacity for doing bulk transport. Okay. On the basolateral surface of the proximal tubule, you also have this basal infolding, again increasing your reabsorptive capacity. This is an electron micrograph. And then all your solute and water gets reabsorbed through and goes into the capillary lumen, which is also fenestrated to enable, again, bulk transport. Note that there are numerous mitochondria, and so these are important for energetics. This proximal tubule does a lot of work, so it's loaded with mitochondria that you can appreciate on electron microscopy, and you will see a number of these pictures over the course of this course. The next stop in the nephron is the loop of Henle. There's a descending limb and an ascending limb. The descending limb essentially is highly permeable to water. Water gets reabsorbed passively because the medullary interstitium has a very high osmolarity, and water gets reabsorbed there. On the other hand, the ascending limb of the loop of Henle is impermeable to water, and this is a segment which is important for reabsorption of the filtered sodium chloride, up to 25% of it. And so this reabsorption of sodium chloride, actually the sodium eventually gets pumped into the medullary interstitium and is important for the generation of this hypertonic, hyperosmotic medullary interstitium. This in turn is responsible for our ability to reabsorb and hold on to water in our system. And again, we'll talk about this. The thick ascending limb is also the site of action of loop diuretics. So there are diuretics, you've heard about this in your cardiovascular section, are responsible for, enable you to get rid of excess water and salt. And it's by poisoning the thick ascending limb and its capacity for reabsorption of 25% of the salt in the thick ascending limb that loop diuretics work. That's their name. They work on the loop of Henle. The main pathway for this is the sodium-potassium 2 chloride co-transporter, which is poisoned by the loop diuretics and is responsible for reabsorption of salt from, again, the lumen into the blood side. The next stop is the distal convoluted tubule in the nephron, which is responsible for about 5% of sodium chloride reabsorption. This is the site of the macula densa, which we talked about. This is a specialized bunch of cells in the thick, in the distal convoluted tubule that sense sodium and chloride. And they're coupled, they come in close proximity to your glomerulus. Well, I'll show you another picture of this. And so coupled to the JG apparatus are responsible for the release of renin in the setting of low sodium chloride flow in the distal nephron. Okay. The DCT is the site of action of thiazide diuretics. Again, thiazide work on the sodium. It's on the sodium chloride co-transporter. In fact, it's called the thiazide-sensitive sodium chloride co-transporter. And that's, again, on the luminal side, coupled to the sodium-potassium ATPase on the basolateral side. We'll go through the mechanism of all of this again. A little bit more about the macula densa. Each distal convoluted tubule comes into close proximity to its own glomerulus. In other words, each glomerulus senses the flow that's in its own distal convoluted tubule, and it's the blood flow in the distal convoluted tubule, the amount of sodium chloride, which is sensed by the macula densa. These are specialized cells here that you can also see very well on light microscopy. And these, again, are in close proximity to these JG cells, juxtaglomerular epithelioid cells that contain renin granules and release renin. So when you have low flow or low sodium chloride that's delivered, let's say you have there's blood loss, there's low blood flow coming through the afferent arteriole, that is sensed by the afferent arteriole, and you get release of renin. At the same time, because you have less filtration through the glomerulus, you have less blood flow and less sodium chloride that's delivered to the distal nephron and to the distal convoluted tubule. That activates your macula densa, and in turn, again, is another stimulus for renin release. Note that if you look at this, you have the efferent arteriole, the afferent arteriole that form a triangle, and there, at the base at the tip of this triangle, you have the macula densa. And again, you can see this here on light microscopy. You have your distal convoluted tubule. It's coming close to its own glomerulus, and this is the macula densa cells near the JG cells in the glomerulus. So that's a mechanism for basically sensing flow and maintaining blood pressure and regulating salt and water reabsorption. The GAG cells secrete renin. You've learned about the renin-angiotensin system in cardiology. You're going to hear a lot more about it during the renal section and again in the endocrine section. The GAG cells release renin. It's a circulating hormone, which then cleaves this other substance that's excreted by the liver, angiotensinogen. Renin converts angiotensinogen to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by the converting enzyme that's in circulation. It's also made by the epithelial cells, highly present in the lung as well. And so angiotensin 2 has two different effects. It can produce, it's angiotensin, so it produces vasoconstriction, and also stimulates aldosterone release from the adrenal glands. And aldosterone has the effect of acting in the distal nephron to increase salt reabsorption. And you could see how this would work if you have, again, blood loss, if you have salt loss, and you have decreased blood pressure. This activates renin through the sympathetic system, or by sensing the decreased perfusion pressure in the afferent arteriole. You release renin. At the same time, because you're going to deliver less salt to the distal nephron, again, that's another stimulus for having renin release. This leads to increased maintenance of blood pressure via vasoconstriction. In the long term, you start to retain more salt in the kidney so you can restore plasma volume. We're going to go again through all of these mechanisms in the next few days. Dr. Barash will make his comeback and teach you all of this. So, and finally, the last stop in the nephron is the cortical collecting duct. This is the segment of the nephron which basically fine-tunes the amount of salt and water that we reabsorb and maintain in our system. You will see it actually responsible for the last 2 to 3% of the salt that's reabsorbed. And so that's the net balance of salt in your body is really determined by what happens in the distal nephron. And you would think that that's not a lot, but actually this is significant. And so we tend to be in a salt-rich diet, and so most of the time we tend to try to get rid of excess salt through our kidneys. But if you're in a salt-poor environment, in a low-salt diet, you lose a lot of salt via exercise or via diuretics. Then the distal nephron really tries to hold on to a lot. There are two types of cells, the principal cells and the intercalated cells in the distal nephron. The principal cells are the site of action of a lot of hormones, aldosterone, atrial natriuretic peptide, and vasopressin, which is important for water homeostasis. They're also the site of action of potassium-sparing diuretics such as amiloride. And then the other type of cells that we have in the distal, in the collecting duct, is the intercalated cells, which mediate acid-base secretion. And so, again, the molecular mechanisms are, well delineated. Your epithelial sodium channel in the luminal surface is responsible for salt reabsorption. This can be poisoned by the diuretic amiloride. The intercalated cells have a hydrogen pump and a bicarbonate chloride exchanger on the basolateral surface that are really important for maintenance of acid-base homeostasis. And so again, if you look under light microscopy, you can appreciate it in the distal nephron. These flat cells are the principal cells, whereas these sort of rounded cells that look a little bit like cushions are the intercalated cells that have these big nuclei and that you can readily appreciate in the distal nephron. As you go further down in the kidney, now all your collecting ducts start to merge together, and then you start getting to the renal pelvis. And so this slide just simply shows that the epithelial layer in the renal pelvis is really continuous with the transitional urothelium that lines the ureter and then the bladder and the urethra. And so this is your simple columnar epithelium, again, in the papillary duct, and then here you see the transitional epithelium, which has multiple layers in the ureter. So a little bit of a few definitions for you. You're going to hear about this. There are a few formulas that you will have to know about kidney function. One of them is the glomerular filtration rate. This is really important. There are automated algorithms which calculate this for you, but it's really important for you to understand how we derive this glomerular filtration rate. You will be measuring this and looking at these numbers all the time in your patients, no matter what discipline you go into. So I think it's important to think about it. So the glomerular filtration rate is simply the volume of plasma that's filtered by the kidney per unit of time. So the units are usually in mLs per minute or liters per 24 hours. The normal GFR is about 90 to 125 in a healthy individual, so that's the equivalent of about 200 liters a day. That's the number I was referring to. So we filter about 200 liters a day into our nephron. Okay, it's estimated by measuring serum creatinine. It's a byproduct of muscle metabolism. It's generated at a constant rate and is freely filtered and not reabsorbed. And so as a result of this, you can approximate the glomerular filtration rate because this substance is freely filtered and is not reabsorbed and it's not generated and it's generated at a constant rate. Okay. The serum creatinine level is inversely related to kidney function via this formula. We will go through the derivation of this formula tomorrow, and then on a Monday we will go through some of the small group questions that will cover how we arrive at this equation and why it's important to know about it. Practically, you can measure the GFR in your patients by asking them to collect their urine for 24 hours over a period of time, and then you measure the amount of creatinine that they excrete over a 24-hour period of time, and you measure their serum creatinine levels, and you can calculate this then based on this by these two simple numbers. Okay. A couple of other simple definitions. What's chronic kidney disease, or CKD? You will hear this term over and over again. That's the diminution of kidney function below normal. If your GFR starts to fall below the 90, there are some definitions for this. Then you have different ranges of CKD, which is reduced GFR. This is gradually associated with metabolic abnormalities that we talked about because there's dysfunction of all the other components of kidney function, essentially, the endocrine function, the filtration function, the ability to handle salt and water and acid base. And this is a major cardiovascular risk factor. It's estimated that 13% of the population in the world will develop chronic kidney disease. Okay? Once chronic kidney disease once it reaches end stage, in other words, when your GFR is roughly in the range of 15 or less, you have reached end stage kidney disease. So this has reached a point where the kidney cannot assume its metabolic and homeostatic functions, and so it's incompatible long-term survival, and this requires dialysis or kidney transplantation for survival. And we will go through what we can do to try to slow down the progression of kidney disease in our patients. At the same time, if they do reach kidney failure, then we can keep them alive by using dialysis and transplantation and prolong their life so they can have a reasonably good lifestyle. So the prevalence of kidney disease and kidney failure is increasing. This is the number of dialysis patients that we have as of 2011. These numbers are going up every year. The major reason why people develop kidney failure in the developed countries is diabetes. We have about 40% of kidney failure is due to uncontrolled diabetes, which leads to kidney damage, and mostly damages the filter, the glomerulus. Okay. Hypertension is the second most common cause, and then inflammatory diseases of the kidney, immune-mediated diseases of the kidney, glomerulonephritis is the third most common cause, and then you have developmental disorders such as cystic kidney disease. There are about 700,000 people in the United States that have end-stage kidney disease. Most of them are on dialysis. A whole bunch of them are on have a kidney transplant. And we'll talk about some of the challenges for allocating organs for kidney transplantation. And again, what we can do to maintain kidneys that are allografts healthy and well. So this is where we are. I think we'll stop here. We'll take a break, and then we'll go through all the other details, in the course of the next few weeks. Thank you. Just go on the computer.
I'm sorry?
Just go where you were before, on the left, yeah. Computer.
Oh.
Great.
I don't know.
From
Presenter.
the left. From the beginning.
No, but they don't have like a presenter.
Huh?
So they don't have the presenters.
You can close that on the left. There you go.
Okay.
So you can, yeah, it's on mute now, then you can turn it on otherwise.
Holly, does this work?
We prefer that you use this.
Oh, they don't want.
Because it's recorded, and if you use this, then they're not going to see it on the recording. Whereas if you use this to point to stuff.
Oh, okay.
Okay.
I see what you mean. Okay. Okay. All right. Good morning. Good morning. Okay, so
Okay, we'll get started.
we're going to get started. So we're going to spend the next 25 minutes talking about urine and urinalysis. As strange as it may sound, it's something that, as nephrologists, we think about all day. We spend our days thinking about patients and their urine samples and what it actually means. So I'm going to try to give you a perspective as to why we're so concerned about urine, what its composition looks like. And we'll start with a historical perspective. So if you think about it, urine was the first fluid that we had access to test. So it's essentially, urinalysis became the first diagnostic lab test to perform that we have evidence of. So the study of urine was called uroscopy till the 17th century. They thought of it as a divine fluid. It was considered a window into the body. If you go through history, there's lots of references to urine and urine composition and using urine to diagnose medical disorders. The 24-hour urine, which is probably the bane of most patients with kidney disease, where we want them to collect their urine for an entire 24-hour period and do it accurately, has been around for over 1,000 years, and we still use it to this day. But like any diagnostic test, they can be overused, right? This is not dissimilar to what we do with radiology, and or at least some radiology and some lab testing today. And when it gets out of control, there's a backlash and a decrease in its use. But it's come back where we now find urinalysis to be useful and relevant to modern day medicine. So when we collect urine, there are different types of specimens we're interested in. The most commonly used specimen that we are interested in is the midstream clean catch. It's non-contaminated, has no epithelial cells, no debris from either the labia or the foreskin, and that's what gets used in most outpatient settings. On the inpatient side, however, a lot of patients tend to have catheters. It makes it easier to get a clean catch specimen, and where possible, we try to get catheterized specimens. Timing of urine samples vary because a lot of substances in urine have a circadian rhythm. Some are present at different times of the day. So depending on what it is that you're testing for, what you're looking for, we look for different samples. So again, the most commonly used is the random sample when somebody shows up in clinic, and you test them when they're in the clinic. If you're looking specifically for certain types of medical conditions that we'll get to, you want the first morning sample. It's the most concentrated sample, and if you think about it, the first thing most people do when they wake up is they go empty their bladders, right? So that's part of the physiology of human physiology. To allow you to sleep for 8 hours is you produce really concentrated urine. So if you're able to sleep for 8 hours and your bladder has to take that urine, it has to be concentrated. And so if you're looking for something in relatively trace amounts, you want as concentrated a urine specimen as possible. So the first early morning specimen becomes that concentrated specimen, and allows you to standardize across patients. For those substances that either have a fluctuation during the day, such as urinary calcium excretion, or for substances where you want to quantify and standardize so you can follow them, we do either timed collections or 24-hour collections. But when you're looking at any fluid, any biological fluid, and you're interested in studying it, there are certain characteristics you want to try to identify. So we're interested in physical properties, chemical properties, and what it looks like under the microscope. What does it have in it in the form of cells, and specifically to urine, what costs does it have? So let's start with physical exam. So urine comes in every color you can imagine. It's like the rainbow, okay? Red, orange, yellow, green, blue, purple. I know you don't believe me, but it's true. White and black. Okay, it comes in every single color. This is usually when people start to pay attention. That's urine. Okay? I'm not making this up. Purple urine. But what you can tell from looking at purple urine is right away you know the urine pH. It's an alkaline pH. You probably know that this is somebody who has a urinary tract infection, because the way you get purple urine is you mix blue and red. Okay, you mix indigo and indirubin, which are metabolites of indican, right? So if you have tryptophan in your diet, you break it down, you get indican. Indican you excrete in your urine. If you have a urinary tract infection, you break it down, your urine's going to look purple. That is going to get your patient's attention. But usually you see this in the ICU. Okay. We see green urine with drugs like metoclopramide and propofol. You can see really bright green urine if you use methylene blue which is commonly used in surgery to find fistulas. I don't have a picture of this, but the blue diaper syndrome is a genetic disorder which is relatively rare, which is classically associated with blue urine, and the diapers look blue. Orange urine is what we see with patients with rifampin. So for patients who are on directly observed therapy for tuberculosis, for example, an easy way to assess if somebody is being compliant to their rifampin dosing is you ask them what's the color of their urine. And if in rifampin, actually, even your tears turn reddish orange, right? So you know whether your patient's taking it or not. You can see white urine. This is tube B is actually urine. And this is when you have urine that's contaminated with lymphatic fluid. So if you have an abnormal communication between the lymphatic system and the urinary tracts, you're going to see white urine because your lymphatic fluid contaminated in the urine. You have lots of chylomicrons. This is an experiment that shows that the white urine is actually white because it's got fat that dissolves in chloroform, and then if you stain with Sudan 3, it turns red. But in addition to the colors, there's a clarity. So most of us are used to looking at our own urine. If you look at your urine, you think of it as clear. But it's not always clear. It can be hazy, it can be cloudy, turbid, milky. And that usually gives you a sense that there's something else suspended in that solution, right? So the more cloudy and the less clear the solution, the more likely that you have particles and the greater the density of particles. The classic particles that don't dissolve, we're thinking of cells, whether it be red cells or white cells. You're thinking of crystals and lipid particles. Those are the classic substances that will decrease clarity. So next step, odor. So yes, classically, urine is described as having an aromatic odor to it. Okay? But if you have a patient with a urinary tract infection, that's when they'll tell you my urine actually smells foul. So urine, initially, when you first void it, without bacterial overgrowth, does not smell foul. Diabetic patients can tell when they have diabetic ketoacidosis because their urine starts to smell fruity or sweet. And then there are inborn errors of metabolism that make urine smell like sweaty feet, smell mousy, rancid, smell like cabbage for your cabbage lovers. And these are clues. So in the pediatric setting, they will give you a sense of what you're looking for. The other physical property that we're interested in is the density or how concentrated is your urine. And there are two ways to measure concentration. So the dry chemistry, what we commonly do in an outpatient setting, is we look at specific gravity. We're looking at how much more dense is the solution than an equal volume of water. And usually specific gravity and osmolality correlate really well. They don't correlate well when you have large molecules like contrast or glucose in the urine. But it gives you a sense of whether somebody is able to concentrate or dilute their urine appropriately. Right? So in somebody who's intravascularly volume depleted, has severe diarrhea, you expect them to be able to hold on to salt and water and have really concentrated urine. If you drink lots and lots of fluid, you should have clear urine that is relatively dilute. The other way to measure concentration is the osmolality, which is measured using freezing point depression. It's the concept that we use all winter long when we add salt to snow. Right? So the more particles you dissolve in water, the harder it is to freeze because the lower temperature it needs. So that decrease in temperature at which water freezes will tell you how many particles you have in solution. So they look at what temperature the urine freezes, and that tells you how many particles there are, and therefore you know the specific osmolality of that urine specimen. There are two conditions where you do lose your ability to either concentrate or dilute your urine. Okay, so classically in sickle cell disease, where there is a lot of sickling and damage to the renal medulla, you lose your ability to concentrate or dilute urine, so your specific gravity remains the same as that of plasma, which is about 1010. You can also see this loss of ability to regulate urinary concentration in severe ATN or tubular necrosis. So then comes the chemical examination. So we use dipsticks. This is what a dipstick looks like. We're interested, it's in the exact same order on all dipsticks because we're looking at chemical reactions. It's based on timing. Okay, so we're going to go through these. So let's start with pH. So is the primary buffer in blood is bicarbonate, and the primary organ responsible for regulating pH in the body is the kidney. So if you don't have a normal pH, the question is, what is your kidney doing in order to get your pH back to normal? So we use the pH in the urine to assess whether your renal response to an acid-base disorder is appropriate or not. So if you have a metabolic acidosis, you expect to see a lot of acid in your urine and a low urine pH. A urine pH above 6.5 in the presence of metabolic acidosis is inappropriate. In fact, above 5.5 is also inappropriate. Whereas if you have metabolic alkalosis, you should see a high urine pH. And if you don't, it may even suggest that you have either intravascular volume depletion or a potassium depleted state that's interfering with your kidney's ability to regulate acid excretion. The next thing we look for in the chemical exam is the presence of heme or blood. So if you see blood positive on the dipstick, your next thought is, okay, I should see red blood cells as well, right? So if you see red blood cells and you have a heme positive, that's hematuria. The classic medical condition, renal condition that we're thinking of that causes hematuria is a glomerulonephritis, okay, which we'll come to over the course. Other things that cause hematuria, pyelonephritis, which is an infection of the kidney, renal calculi, trauma to the kidneys, tumors of the kidneys, all cause hematuria. But if you see heme positive on the dipstick and you don't see red blood cells on the microscopy, so there are no red blood cells, that would suggest that you're getting a kind of false positive where you have hemoglobin reacting or myoglobin reacting with the test strip. So that would suggest, if you have myoglobin, that you have rhabdomyolysis, or if you have hemoglobin, it's hemolytic anemia, or a transfusion reaction that causes hemolysis. Severe burns can do this. Severe malaria can do this. Okay. So now you have a way of identifying somebody who potentially has rhabdo without doing anything other than a dipstick. The most important thing on the dipstick that we're primarily interested in as nephrologists is the protein excretion. Right? So this gives us a sense of whether somebody's kidney is functioning appropriately or not, whether they have intrinsic renal disease or not. So all of us excrete some amount of protein. It's a relatively small amount. It's about 150 milligrams per day. More than that is considered abnormal, except pregnant women sometimes excrete more. They can excrete up to 300 milligrams. And nephrotic range proteinuria is about 3.5 grams per day. And patients who have nephrotic range proteinuria or more, people can excrete 10, 20, 30 grams of protein a day. Their primary complaint when they come to clinic is, after I empty my bladder, it looks like I've got a beer head in the toilet bowl. Okay, so that actually is a picture of urine from a nephrotic syndrome patient. That's, okay. And when we look at proteinuria, we break it up into two categories. Either you have persistent proteinuria or intermittent proteinuria. Intermittent proteinuria does not have the same negative consequences. It does not have a pathognomic consequence. So intermittent can be either orthostatic, that is proteinuria associated with standing for long durations. If you look at your own urine, you'll see that you have more bubbles in your urine in the toilet bowl at the end of the day than you do usually at the beginning. That's normal. That's what we refer to as orthostatic proteinuria, and that's why it's better to measure protein at the start of the day. The other is functional proteinuria, which occurs in certain situations of following a febrile episode or following strenuous exercise or seizure-like activity. It's persistent proteinuria that we actually care about. That's what's more concerning and more indicative of something that's going to be progressive. So it depends on where the protein's coming from, right? So if we can think of it as, again, pre-renal, renal, and post-renal, so as the source of the protein. So most commonly, protein in the urine is renal in origin, suggesting that you either have a glomerular injury or a tubular injury, or you have a combination of the two. You can have proteinuria with perfectly normal kidney function and a healthy glomerulus if you have either abnormal light chains that get filtered through a normal glomerulus, if you have myoglobin or hemoglobin, free hemoglobin or myoglobin in the blood that again gets filtered through the glomerulus and gets excreted. And you can have proteinuria, small amounts of proteinuria in patients who have either prostatic disease or urinary tract infection. Now, you can get false positives if you have a very alkaline urine. It can give you a false positive test. So patients who have no proteinuria may have, 1+ or 2+ on the dipstick. And you can get false negatives if you have positively charged proteins. Okay? The dipstick tests for negatively charged proteins such as albumin and albumin-like protein. So if you have just Benge-Jones proteinuria, you're going to have large amounts of protein in the urine, but your dipstick is going to be negative. Okay? And when we measure proteinuria using the dipstick, we have a semi-quantitative sense of how much protein. So depending on the intensity of the reaction and the color change on the dipstick, we can tell whether it's 30 milligrams per deciliter, 100 milligrams per deciliter, all the way up to 2,000 or more milligrams per deciliter. The problem with this, however, is and the reason we think of it as semi-quantitative is it doesn't give us a precise total amount. It tells us concentration. And concentration depends on volume. So if you're excreting a gram of protein and you make a liter of urine, your concentration is very different than if you have a gram of protein that you're excreting in 3 liters of urine. And the volume depends largely on how much fluid you're drinking. Okay? So if you want a more quantitative or a more precise assessment of protein excretion, we do either timed urine collections. So we know here's the total amount of protein excreted over 6 hours, 8 hours, 12, 24 hours. Okay, and then you multiply appropriately to see how much protein is being excreted per day. Or you do what's called the spot protein creatinine ratio, since we know that everybody's creatinine excretion is fixed for a 24-hour period. If I measure both the protein concentration and the creatinine concentration and I know the ratio, I can extrapolate that to a 24-hour period. Certain things to remember: the proteinuria the dipstick primarily detects albumin. When we say proteinuria on the dipstick, it's not useful for detecting tubular proteinuria, and it has a lower limit of detection. So less than 20 milligrams per deciliter. So if you have very dilute urine or small amounts of proteinuria, that's going to be missed on the dipstick. Okay, but and hence the term microalbuminuria. Okay, but that still has clinical significance. So for patients who have no proteinuria, but you suspect that they may be leaking protein, such as long-standing diabetics, we actually look for these trace amounts of protein using different methods. Nephelometry is currently the standard for assessing microalbuminuria. Okay, but it has its own clinical significance and does portend the risk for progression. Okay, things that we don't want to see in urine. So we shouldn't see glucose in urine. We normally don't excrete glucose. We normally reabsorb any glucose that gets filtered through the glomerulus by the okay, except if your serum concentration of glucose is above 180 milligrams per deciliter, you're not going to be able to reabsorb all the glucose that gets filtered. So you're going to have some spillover. So uncontrolled diabetics will have glycosuria. In the developing world, where glucometers and finger sticks are expensive, this is a cheap way to assess adequacy of blood sugar control. If you don't have glycosuria and your dipstick's negative, your blood sugar is probably reasonably controlled. In certain circumstances, you can have glucose in the urine or glycosuria with a normal blood sugar. That condition is referred to as orthoglycemic glycosuria. You know, it's a mouthful, but that primarily represents a proximal tubular dysfunction. That is, your ability to reabsorb the glucose that you're filtering has failed. You know, classically seen in Fanconi syndrome, also seen in certain drug toxicities, such as HIV patients who are on long-standing tenofovir. Okay. The other thing that you don't want to see in urine is ketones. Okay. So if you have metabolic ketosis, such as what you'd expect to see in diabetic ketoacidosis, starvation ketosis, or alcoholic ketosis, those ketones will show up in the urine. The kidneys are very good at excreting ketones. The one thing to remember, however, is that there are several types of ketones, and the relative concentration of those ketones varies depending on the medical condition. So, for example, with diabetic ketoacidosis, the primary ketone produced is beta-hydroxybutyrate. The primary ketone, however, that the dipstick detects is acetoacetate. So you can have mild diabetic ketoacidosis and a negative ketone on dipstick. Next is you want to look for evidence of a urinary tract infection. Okay, so certain gram-negative gram-negative bacteria will break down nitrate to nitrite, which is then reacts with your dipstick and comes back positive. So if you have a gram-positive bacteria, this is still going to be negative. You're not going to see it, or you're also going to get false negatives in patients who are vegetarians. The other clue to somebody who has a urinary tract infection is the presence of WBC. You normally don't see WBC in the urine. You see them only if you have an inflammatory response in the kidney or you have a urinary tract infection. Leukocyte esterase is part of granulocytic WBC. So you're only going to see it when you have granulocytes. You're not going to see it when you have lymphocytes. So if you have renal TB, you will not see a positive leukocyte esterase. If you have chlamydia or yeast infections, you're not going to see a positive LE. But if you have a bacterial urinary tract infection, you will see this. Okay? You can see false negatives in patients who have heavy glycosuria or heavy proteinuria. In the interest of time, I'm not going to talk about this, but essentially bilirubin and urobilinogen are also filtered through the glomerulus, show up in the urine, allow us to differentiate between different medical conditions that are associated with elevated bilirubin levels in the serum, okay, such as liver disease, obstructive jaundice, or hemolytic anemia. So, quick word about the 24-hour urine collection. We still do this. We don't do it as frequently as we used to, but it still has a role in nephrology. We're still interested in identifying substances that have a circadian variation to that excretion. So you want to collect it for an entire 24 hours, so you don't inadvertently collect urine when there's there's less secretion or more secretion. We use it to estimate clearance, which is another way of saying we use it to estimate glomerular filtration rates. We use it for dietary assessments. Remember, what you absorb, if you're in a steady state, is what you're going to excrete. So how much salt you eat is how much salt shows up in your urine. Okay. So the challenge is explaining how to do this to patients. Okay. So how do you do a 24-hour urine? The rule is you start with an empty bladder and you finish with an empty bladder. So we tell patients, you wake up in the morning, empty your bladder in the toilet bowl. When you empty your bladder in the toilet bowl, you've basically discarded all the urine that you made overnight. Now the clock starts. So you start with an empty bladder. Everything that you make, every time you want to void from that point on for the next 24 hours goes into the bottle, not into the toilet. If the patient wakes up in the middle of the night to void, goes into the bottle, not into the toilet. When they wake up in the morning, they now have a full bladder. Where do they go? Louder. Bottle. Because that's urine produced overnight that goes into the bottle. The test stops at the same time the following day with an empty bladder. Okay? That is incredibly hard for patients to follow. So you'll get patients who come in with 3 or 4 jugs because they wanted to impress you. You'll get people who pour water into the urine because they thought they needed to fill it up. You'll get patients who collect urine for 48 hours. Okay? It's a challenge and people don't like doing it. And they especially don't like getting on the subway with 2 liters of urine. But that's what we need them to do. Okay. Microscopy. We're looking for cells and COS, right? Because cells and COS signify abnormalities and will tell us what's going on. So will give us clues as to what we're looking for. So if you see RBCs that are normal shape and size, that is, they're isomorphic RBCs, means that they haven't been damaged by passing through the glomerulus. They haven't been damaged by the filtration process. That means they've entered the urine below the glomerulus. So that can happen if you have a renal calculi that is scratching against the inside of the ureter, causing you to bleed. If you've had trauma of some sort, if you had a cyst of some sort rupture, if you have polycystic kidney disease, or you have a renal tumor. Okay? Or you have a bladder infection or some sort of inflammation within the bladder. Those will all give you isomorphic RBCs that are normal in shape and size. If, however, you have dysmorphic RBC, where you have a small bit of the RBC pinched off, or they don't look regular and smooth and biconcave, that suggests that those are RBCs that went through the glomerulus. The only time they're going to go through the glomerulus is if you either have glomerular nephritis or if you have vasculitis. If you have some sort of inflammation at the level of the glomerulus or above it, and those RBCs usually get trapped in Tham-Horsfall protein. So the tubule secretes some protein, normal amount of protein. The RBC goes into the tubule, gets trapped in it, and you get an RBC cast. Okay, and we'll show you some pictures. If you see WBC in it, suggests either that you have inflammation or an infection. So urinary tract infections are the single most common reason for you to have WBC in the urine. The other reasons to have them, you can see WBC in the urine if you have inflammation of the glomerulus and glomerular nephritis, or you have an interstitial nephritis, like an allergic reaction to a drug. Okay? Where you see a large number of eosinophils, those eosinophils will appear in urine. You can see tubular cells, where you have tubular damage and tubular cells are sloughing off, and those will form tubular casts. In those situations where you have fat being excreted, or hyperlipidemia, you can see fatty casts in oval fat bodies where you have fat trapped in cells. In infections, you can see yeast and bacteria actually appear in the urine, so we're looking for those. In normal individuals, because we secrete TAM-Horsfall protein into the tubule, you're going to see some of that TAM-Horsfall protein. It looks cast-like. They look narrow, thin, long tubes, which are clear with no debris in them. Those are called hyaline casts. Those are benign, and they're present in everybody. It's normal urine. But if the casts look broad, they have this waxy appearance, that suggests that there's dilatation of the tubule, suggesting that there's some sort of renal disease. There's decreased GFR. There's hyperfiltration in those nephrons where those casts are coming, suggesting that there is ongoing renal disease. Okay, so this is what microscopy looks like. So the picture in the upper left-hand corner is low-power urine microscopy. You can see lots of cells. You can't tell what cells they are at this magnification. This in the middle is a cluster of cells probably packed into cast. So this is a cellular cast. You can't tell what type of cast, just that it's probably red and white cells, or maybe just one or the other. You stain it. You can see these clear cells, circles, are RBCs. These are WBC, again at low power, so you can't tell what type of WBC, but this is what a stained urine sediment would look like. This is a picture at the lower left-hand side of crenated RBCs. So these are RBCs in really dilute urine. Very concentrated urine, but this is also a patient with sickle cell disease, so you can see some sickle cells. Okay. At higher concentration, you can see different types of WBC in the urine. This is a classic example of bubble cells. This is tubular cells with these large vacuoles that look like bubbles. Okay. This is what we're classically looking for when we're looking for glomerular nephritis. Right? For evidence of glomerular nephritis, you're looking for this cylindrical shape cluster of cells. So this is a granular cast where all the cells inside have broken down. So you know there were cells here, but they've all disintegrated and they look like just dots, just granules left over from cell breakdown. This, on the other hand, is a cellular cast. As you can see, you can barely see the outline, but you can say it does have a cylindrical shape to it. And it's got lots of cells. The types of cells here are hard to tell because we haven't stained it. You stain it and suddenly look here. Mostly WBC, right? So this is a WBC cast. This is a bilirubin pigmented cast. Same thing here. In a slightly different picture, you can see two casts right next to each other. Stain the cast, predominantly WBC. This is a picture of bubble cells. This is a picture of fat within epithelial cells, suggesting this is somebody with nephrotic syndrome and hyperlipidemia. These are fragments, low power and high power fragments of cellular casts. And this is an example of proximal tubular epithelial cells, what you see in proximal tubular injury from tenofovir. And if you don't remember any of those pictures, this is the one picture you want to walk away with. This is muddy brown casts. Okay, so this is what is most commonly seen in the hospital in patients with acute tubular necrosis. So these are casts with lots of tubular epithelial cells. So the cells lining the tubules are starting to slough off into the protein and break down. And this is diagnostic of acute tubular necrosis. Okay, right. Thank you.